Thank you for that really awesome introduction. It's a pleasure to be here, and thanks to everyone who organized it and put the event together. As we mentioned, today I'm going to be talking about some of the translational work that I've done, trying to understand the magnitude of health disparities faced by LGBTQ individuals, as well as some of the mechanisms and developmental processes that unfold and explain those effects, and some of the intervention and implementation work that I've done to try to get effective interventions out into the population to address some of these health issues. A couple housekeeping notes. I'll say that's my Twitter handle, @Mustanski. If you're an avid Twitter person, I'm trying to get on Twitter more, so you could send me a tweet of how great my talk is if you like. And also I'm going to be using some different acronyms throughout the talk. We have a bit of an alphabet soup in our community of different acronyms that we use. So I'll be using LGBTQ to stand for lesbian, gay, bisexual, transgender, queer. I also will be saying SGM, or sexual and gender minority, which is a more recently coined broader term that is an umbrella term for people who are LGBTQ, as well as individuals who may not identify that way but have same-sex attractions or engage in sex or relationships with people of the same sex or gender. And I might be using MSM from time to time, which stands for men who have sex with men. So I'll try to keep the jargon down, but just to give you a forewarning, those are some of the terms I'll be using. As was mentioned, I direct the Institute for Sexual and Gender Minority Health and Wellbeing at Northwestern. We call it ISGEM for short, because that's kind of a mouthful. And it's the largest LGBT health-focused research institute in the world. We have 10 full-time faculty, 30 faculty affiliates, about 10 postdocs, and 65 staff that work within the institute. So a lot of the work that I'll be presenting would not have been possible without this amazing team of people that help make the work possible. Today, whether it was intentional or not, happens to be October 11th, which is National Coming Out Day. October is LGBT History Month, and October 11th is National Coming Out Day. It's a time to think about the experiences of people as it relates to coming out and some of the challenges and successes and benefits that people accrue when they come out about their sexual orientation or gender identity. So I'll just start by coming out. If you didn't know yet, I'm a gay man. Thank you. All right, on to the meat of the talk. So in terms of when we think about some of the health disparities that are experienced by the LGBT community, there's been a lot of actual policy developments and developments as it relates to federal policy and recognition of the LGBT community and LGBT health as a priority issue. And one of those was that in Healthy People 2020, was the first time that the federal government recognized LGBT people as a health disparity population. So every 10 years, the federal government comes out with its areas of attention for health disparities within the population. So Healthy People 2020 was actually developed in 2010, and it was goals for understanding and addressing health disparities by 2020. And the goal is to sort of monitor these disparities and understand the extent to which we're putting in place services and interventions that help reduce some of those disparities. And when they did this in 2010, when they included LGBT people, that was the first time in history that they had included LGBT people as a disparity population. So when they did Healthy People 2010, there was no mention of the LGBT community. And so this was an important development for the population, that we were getting that kind of recognition. And this also meant that there was more attention to the collection of information about LGBT health within federal health surveys, federal health initiatives. And some of the disparities that are documented in that report were that LGBT youth are 2 to 3 times more likely to report making a suicide attempt. LGBT youth are more likely to be homeless, with some estimates as many as 40% of homeless youth are LGBT. Lesbians are less likely to get preventive services for cancer, which primarily are cancer screenings. Gay men are at higher risk for HIV and other sexually transmitted infections, especially among communities of color. Lesbian and bisexual women are more likely to be overweight or obese. Transgender individuals have a higher prevalence of HIV, STDs, victimization, mental health issues, and suicide, and are also less likely to have health insurance than heterosexual or LGBT individuals, and then also high rates of substance use within the population. So these are important disparities that have been documented, that we have population-based data for many of them. I would say the trans health issues acknowledged don't have less data. We haven't had as much population-based data that's helped us understand transgender health disparities, but these are very well documented disparities with many studies to support them. And I think what was also quite important about the Healthy People 2020 initiative is that in documenting these disparities, it stated that that to understand LGBT health, you have to start by understanding the history of oppression and discrimination that these communities have faced, and that these what are oftentimes called minority stressors are the factors that play an important role in the development of these health issues. And that social determinants affecting the health of LGBT individuals largely relate to that oppression and discrimination. So social determinants are things like legal discrimination in access to health insurance, employment, housing, lack of access to legal recognition of marriage, adoption, retirement benefits, laws protecting against bullying in schools, or lack of social programs or health programs targeting or inclusive of this population. So these are the social determinants that play a large role in us understanding the existence of these disparities. So several years back, I published a paper in American Journal of Public Health that asked the question, what would it take for us to create a world where we didn't have these health disparities? And I think it's a provocative question to think, how would society need to be changed? If we're saying that it's social determinants that drive these health disparities, what would be the changes that we would need to see in order to live in a world where 5-10 years from now, LGBT young people have the same health status, the same access to health care as their heterosexual and cisgender peers? And as soon as you start thinking about that question, you immediately realize the ways in which health has a multi-level component, that we have different levels of experiences, the structure of society that drive our health. That it's not just our individual behaviors, but it's our relationships, it's policies, it's the neighborhoods and communities we live in, the schools that we go to, how they treat people. And so part of what we did in this paper was talk about what would be some of the changes at each of these different levels, what's been called the ecological system, that we would need to have LGBT youth be on par with their heterosexual and cisgender peers. And so I'm going to take you through some of those kind of observations that we had of how we thought about social change to take away these health disparities, eliminate these health disparities. That'll be probably the first half of my talk, and then I'm going to switch and talk a little bit more about my own research and some of the intervention work that I've been doing more recently. So at the largest, most external system to a person is what's referred to as the macro system. These are the social, political, and institutional forces that influence our health and well-being. And one example of that is stigma, for example. If people experience stigma, there's discrimination, there's statements that are negative about that population. There's a lot of research that shows that stigma has ways of getting under our skin and directly influencing our health. And so we know that stigma would have to change. And one form of that stigma is what's called sexual prejudice, which has also sometimes been referred to in the literature as heterosexism or homophobia. Some people have stopped using the word homophobia because it implies that there's some kind of actual fear of gay people. A phobia is something that you have a fear of, and that actually that concept of homophobia is more about prejudice about people, not a fear of people. So sometimes they use the word sexual prejudice or heterosexism. And that's about negative society attitudes towards individuals who are part of the sexual and gender minority community. So how are these forms of stigma sort of structured and institutionalized at this level of the macro system? So things like law and social policies. Do we have legal employment discrimination, for example? Can you fire someone in that state because they're gay or because they're transgender? And we'll talk a little bit about that later in terms of the fact that there are a lot of states where that still is possible. And so that's an example of a macro system. If we still have laws on the book that you could fire someone for being gay, it's hard to expect that we could live in a world where LGBTs would have the same level of health status as their heterosexual and cisgender peers. We also know that religion is an important part of the macro system, that people's beliefs that they have, religious beliefs, do play a large role, particularly in American society. And we know that attitudes towards homosexuality are aligned with religious beliefs, that there are differences in religious traditions and religious practices as they relate to people's attitudes towards the LGBT community. And I think if we were going to live in a world where there was health equity, where there weren't these disparities, individuals wouldn't have to choose between their religion and their sexual orientation. Another level within the macro system is our educational system. And one of the things that you may or may not know is that in the United States we have what are in some states called no promo homo laws, which means that if a school district talks about homosexuality or the LGBT community in sex education or in educational programs, they have to do it in a negative way. So you either can't, so some places you're actually not allowed to talk about sexual orientation in schools, and in some states, if you talk about it, it has to be negative. So for example, in Alabama, sexual health education classes must emphasize in a factual manner and from a public health perspective that homosexuality is not a lifestyle acceptable to the general public and that homosexual contact is a criminal offense under the laws of the state. So we have laws like this, for example, and you could imagine it would be nearly impossible for us to achieve health equity for the LGBT community for people who live in a state where the only thing they hear about their community, the only thing they hear about who they are is something negative. We also know that it's not just these policies in schools, but things like school climate. What that means is school climate is, in the literature, is often defined as things like policies that reduce bullying, anti-bullying policies, anti-discrimination policies, schools that are safe from violence and victimization for LGBT students, employment non-discrimination policies for staff. So you can imagine if a teacher can get fired because they're gay or lesbian or bisexual or trans, that sends a very important message to all the students in the school about what it means, what's the status of somebody who's from that community. We also have to think about, is the school welcoming to LGBTQ families? If a student has same-sex parents, for example, is that a school where those families are welcomed and supported? Do they have things like gay-straight alliances that build supportive connections amongst LGBT students within the school and also between LGBT students and non-LGBT students within the school? Do they have their curriculum, is it inclusive of sexual and gender minority history? Does it talk about historical figures that are LGBT? So imagine, similar to the parallels that are drawn about the ways in which history classes may only tell the history of white America. It's the same thing when you think about history talking about LGBT people. If you're an LGBT student and you never hear about anyone LGBT in history, that also sends a message to your understanding of yourself and your role in the world. And actually some states, California recently became the first, and my own state of Illinois became the second, that actually have laws that say that history lessons in schools have to be inclusive of LGBT people and talk about LGBT history. And what's interesting is really strongly designed research has shown that these kind of climate issues are directly related to health. That states that have these policies, that schools that have these policies, not only actually are the LGBT students doing better, but the heterosexual students and the cisgender students often benefit from these policies as well. So it's not just schools. As we move closer and more sort of inward from society at large, from laws that might be national or state, and we start thinking about neighborhoods and communities, we can think about things like workplace supports and non-discrimination policies within settings that are supportive of LGBT people, the extent to which there's violence and hate crimes within a community that certainly sends an important message to the LGBT members of the community. Are there legal barriers to family formation, things like adoption? Are there organizations that are supportive of the SGBM community? Are there welcoming healthcare organizations? Do trans people feel like they have providers that are familiar with their healthcare needs? And as we talked about before, when we talk about these sort of structural factors, In many states, you can still be fired for because of your sexual orientation. So if you disclose your sexual orientation to your boss, you could be terminated under those laws and statutes in that jurisdiction based on your sexual orientation. So I think some people forget about this when they think about, oh, we had the Supreme Court decision that's legalized same-sex marriage in the United States. That's a fantastic development, but you could be married one day and fired the next because you got married because of your same-sex marriage. I also think a lot about romantic relationships and the important role that romantic relationships play in people's health. That's one of the areas of research that I do, is understanding how romantic relationships play a role in people's mental health, health behaviors, physical health. And we know from a large history of research that married heterosexuals who are satisfied in their relationship, it's an important caveat, reap numerous health benefits. So that being in a healthy romantic relationship is good for your health. And we also know that there's a key task of adolescence is the development of social skills and self-awareness for romantic relationships. So, some of you guys are undergrads, not that long since you've been out of high school. You probably can remember the extent to which your brain in high school was so fixated on social relationships, romantic relationships. For some people, that's a life course experience, but it's also very particularly a task of adolescence is forming healthy social relationships, practicing out romantic relationships, having some relationships that maybe don't go so well, and you learn that, that's not what I'm looking for in a relationship. That's an important task that we have in adolescence that gives you skills to have healthy romantic relationships in adulthood. But if you're, say, the only out gay kid in your school, you're going to have some challenges if you're, say, a young gay man finding a boyfriend, for example. If there's only one other gay student in your school and that's not who you want to date, you're going to have some challenges. And so I'm going to come back to that theme a little bit in terms of thinking about romantic relationships and health. And we actually really don't have much research on healthy romantic relationships in the SGM community. Particularly, I often ask the question, well, what comes after gay marriage? Should be happy marriages. And we need to help people have happy marriages. But a lot of people don't have role models for healthy relationships. And so we need to give couples skills for healthy relationships. And one of the things that we just recently published a few months ago in Journal of Abnormal Psychology was a study where we were following LGBT youth over time across development. And one of the things we looked at is we've shown in numerous papers that experiences of victimization and bullying in high school years have a detrimental effect on students' mental health. It increases depression, increases symptoms of PTSD, increases thoughts of suicide attempts, substance use, the list goes on. Bullying and victimization is not good for your health. What we've been interested in a long time is trying to understand what might protect against those negative effects of victimization. And we've studied a variety of different social relationships over the last decade. We've looked at peer relationships, family relationships, and we found in that research that having supportive parents, having positive relationships with your family is good for your mental health. Having good social relationships, having friends is good for your mental health, but it doesn't protect against the effect of victimization. It doesn't reduce the effect of victimization's effects on your mental health. And so we've been looking for a while to see if we could find something that actually had that protective effect. And just this year, we published this result looking at romantic relationships. And what we found was that teens who were in healthy romantic relationships were actually buffered against the effects of victimization. So what you see in this figure is a figure from that article where you see how in those youth with the dotted line who were not in a relationship, and this is within person actually over time data, as the amount of victimization they experienced increased, so did their psychological distress. So psychological distress is also sometimes called depressive symptoms. So we saw that went up as they experienced victimization. For the youth who were in a romantic relationship, or at times when they were in a romantic relationship, they were actually buffered against that effect of victimization. So this is actually one of the first protective factors we found in the true meaning of the word protective, meaning that it reduces the effect of a negative threat to your health. And so we're very excited in understanding, again, about the importance of healthy romantic relationships for LGBT youth. We know families are also an important system. We know that family support has effects across a variety of different health outcomes, that parental support is essential for all children, but maybe essentially important for LGBT youth who may need some additional supports because of some challenges they may face in schools or in other settings. And we've been increasingly interested in how do we facilitate strong parenting practices for parents of LGBT youth. Until recently, there were actually less than, you could count the number of studies that had ever studied parents of LGBT youth on one hand. Not an area that there's been a lot of research in, and it's just starting to take off. And we're really interested in how can we help parents who have LGBT kids be the best parents they can of their children. And it's definitely a request that we've gotten from a lot of parents when we've done interviews with parents. Parents really want to understand, how do I help my child date, for example? If they're heterosexual, they may not know much about finding a dating partner that's of the same sex. And so they really want some help to be good parents to their children, and we're really interested in creating services and programs to help those parents. This is a recent study that we reported looking across 3 different samples, 2 studies that were cross-sectional, 1 study that was longitudinal, looking at parenting practices. So most of what's been in the literature so far has really focused on parental support. Are parents supportive or are they not supportive? But there's a lot more to parenting than just being supportive. There's also monitoring your children's behavior, knowing what they're up to. And there's a lot of literature showing that those factors are important in reducing adolescent risk-taking behavior. So if your parents know where you are, they know what you're up to, they know who your friends are, you're less likely to drink, you're less likely to use drugs, you're less likely to get into conduct problems. And what we were interested in, how does this apply to LGBT youth? Because we don't actually know much about how parents monitor their LGBT youth. And so what we found is that we asked some general or sort of typically used parental monitoring questions, which is like, do you know where your kid is after? These are actually reported by the youth. Do your parents know where you are after school? Do your parents know who your friends are? Do you tell your parents when you're going out of the house? Do you tell them when you're going to be back? Those are examples of parental knowledge of what children are up to. So we use those typical measures. And then we also asked those kids the same questions, but when they were doing something that was connected to the gay community. Do you tell your parents if you're hanging out with friends who are gay? Do you tell your parents if you're going to a social event that might be connected to the gay community? And what we found is that kids were much less likely to tell their parents about times in which they were connected to the LGBT community, which if you're a parent, you know, if your kids are purposely leaving out an important part of their life, it makes it harder to monitor them and protect them. And so that's an important thing that we have to think through of how could we help parents do that in a way that's more effective. We also found that parenting practices were consistently associated with teen reports of binge drinking, and there were inconsistent relationships across study in terms of marijuana use and HIV risk behavior. This is an example of the association we found in a longitudinal study reported in that article for binge drinking. And what you see is that in those youth who had lower levels of parental monitoring, they showed higher levels of binge drinking, and there was an acceleration in binge drinking across development, which is relatively normative. We know that drinking increases from adolescence to young adulthood. But what you could see was that those kids who had more parental monitoring were drinking less, reported drinking less in their teen years. That effect tended to disappear into your 20s because it's less typical that you might tell your parents that what you're up to and where you're going when you're in your 20s. So that effect of parental monitoring is what we might call an adolescent limited effect, that by young adulthood, parents are doing less monitoring of their kids, and that's probably developmentally appropriate. So I want to return to what I said earlier about a gay kid in a school who might have one other gay student and sort of thinking about if that's who they want to date and if not. And I think it's an opportunity to sort of illustrate the difference between equality and equity. Has anyone heard sort of that concept before? Okay, good, I'm glad. So, you know, what you can see is the example of equality. On the left, everyone gets the same. So you can see there's 3 different children, 3 different heights. Everyone's getting the same, and that means for one of the kids, he doesn't get to see over the fence. The difference on the right is health equity, which is that we want to give everyone the same opportunities, which may mean that some people need more resources than other people to reach that same opportunity. And so when we think about LGBT health equity, we think about that issue of, say, romantic relationships. Maybe every kid in a school would like a little help finding a romantic partner, but we might need to help the gay kids a little bit more because they might have more challenges in forming healthy romantic relationships because they're from a minority population. There's few other partners available to them. And so again, in this article, we talk about challenging that idea and thinking about If we really wanted to create health equity, it might mean that we're helping gay kids date each other. And that might actually be a really important intervention. I think another sort of controversial question is, should we make individuals change? Is there something gay kids need to do to make their health better? Are they responsible for their own health? Do they have to find ways to deal with these forms of oppression and stigmatization? And I think that's a philosophical debate that we could really wage into in a good bit of depth. I would argue that the people who are the recipients of stigma and discrimination are not the ones who are responsible for addressing that stigma and discrimination. It's the majority community that perpetrates or are part of the perpetration of that discrimination and stigma. At the same time, society is not going to change overnight. We're not going to get rid of anti-gay stigma or anti-trans stigma tomorrow. And so I do think there are things that we could do to help individuals cope within the environment and the realities that we live in. And so what might interventions look like that could teach coping skills to LGBT youth so that they could cope with the environments of oppression and stigma that they may encounter? And I also think we have to be careful about how we think about coping and how we think about people thriving in the context of that kind of discrimination and oppression. So there's been some really interesting work published recently where they looked at how some LGBT young people cope with that discrimination by really investing in success in achievement-oriented activities. So if you could imagine if you're growing up and you're questioning your acceptance from your family, from your peers, you feel like your acceptance and love is conditional on who you are, you may say, well, I'm going to really do well in school. I'm going to be really good at sports because those are things that I can achieve that would bring me that acceptance. But if you overinvest in things like that, it has other consequences to your health. If you're obsessed with doing well in school, if you have to get perfect scores on every test because you're worried that you won't be accepted if you don't, that has long-term consequences that are not adaptive across development. And so we have to really think about coping and response to the stressors in, I think, more sophisticated ways. So I'm going to switch gears, and I'm glad you got me some water because I'm actually going to need it, and talk a little bit now about some of my own work, which is more focused on HIV. And talk a little bit about some of the intervention work that we've been doing around addressing HIV disparities in the community. So this is data from the Center for Disease Control through 2015. It's their relatively most recent release data. And what you can see is from 2010 through 2015, the majority of HIV infections in the United States occur amongst men who have sex with men, or MSM. HIV is very efficiently transmitted through sexual practices, and gay men are disproportionately impacted by that transmission dynamic. So gay men represent the majority of HIV infections in the United States. And what we've seen is over time actually declines in other populations. So the number of diagnoses over time has gone down in heterosexual populations. It's gone down in people who inject drugs. Overlaid on top of that is we see some big age differences. So the largest group of new HIV transmissions is occurring amongst 25 to 34-year-olds, so young adults, who've shown a 23% increase in the number of new diagnoses in the United States from 2010 through 2015. And we've started to see a stabilization amongst teens and young adults, 13 to 24. That purple line was actually showing some pretty big increases until more recently when it started to stabilize at a very high rate as well. And then we're seeing declines amongst adults. We also know that there's major racial disparities overlaid on this. So African American young men represent the majority of these HIV infections in these younger groups. Latino young men are the only group that are now showing an increase in new diagnoses. And we suspect that we may see increases in white, young gay, and bisexual men in the future as well. Every 44 minutes, a 13 to 29-year-old gay or bisexual man gets diagnosed with HIV in the United States. So in the course of my talk, we could think that one young man would get diagnosed with HIV. So it's an epidemic in the United States. It's something that I think people often think is over, that it's been taken care of, that it's resolved, we don't have to talk about it anymore. Everybody knows about it, and that is just simply not true. It's that marginalized populations are still disproportionately impacted with HIV in the United States. Now, in the United States, the Center for Disease Control sort of collates a list of what are evidence-based approaches for HIV prevention. So these are behavior change interventions, health education, sex education programs that have been shown to reduce people's risk of acquiring HIV. And they identified 93 evidence-based HIV risk reduction programs. 25 of them, of those 93, this is when I last checked, were for youth and adolescents. How many of those 25 do you think are focused on gay and bisexual men? So how many of those 25 for youth and adolescents are targeted at young gay and bisexual men? Shout out a number. 25 out of 25. Okay. It's an optimistic audience. Anyone have an alternative guess? 2 for emerging adults, 0 for adolescents. So despite the fact that young gay and bisexual men represent the majority of HIV infections, or the group where we're seeing increases, this is not where we've been addressing services. This is not where we've been doing science. And the challenge that we have is that most funding for HIV prevention has to be tied to using an evidence-based practice. So you have to use a program to get federal funding and oftentimes state and local funding as well. If you don't have an evidence base, you can't deliver services. And it's what I would say is an example of a lack of science leads to a lack of evidence, to a lack of prevention, and a growing epidemic. So I think we can also think of this, we talk about health inequities, this is a scientific inequity. We're not doing science in this area, so we don't have evidence, so we don't have programs, so we're not doing prevention with this population. So what drives this scientific inequity? Well, one is the imposition of ethical and regulatory obstacles to research with LGBT teens. And I'll talk a little bit about some work that I've been doing more recently on some of the ethical questions of doing research with LGBTQ teens. And then also the fact that scientifically, we haven't done as much science in this area. We don't know that much about how to reach teens, how to enroll them in research, how to follow them, how to conduct these kinds of studies. One of the things that in 2011, I wrote a paper about some of the challenges I experienced in getting IRB approval for a study of LGBT teens. It was a 2-year grant that I had, and I spent the first 10 months of that 2-year grant trying to get IRB approval. And I needed to get a waiver of parental permission because I knew that I could not recruit the young people into the study if they had to get their parents' permission. Many of them weren't out to their parents, and it was just impossible to recruit a sample if we had to get the parents involved. And the IRB had a lot of reservations about me doing the study without parental permission. And one of the things that I wrote about is really described how we did that study. We did eventually, after 10 months of discussion, get IRB approval with a waiver of parental permission. And what we found is that the majority of the participants, about 70% of them, said they wouldn't do the study if they had to have their parents' permission. And those who did say they would get their parents' permission were different than the ones who wouldn't. And so if we only studied gay teens who are willing to get their parents' permission, we would get a very distorted view of the health issues facing that population. And so what I like to say is gay people do not emerge at age 18 fully formed like the Greek goddess Venus from the sea. We can't just start studying LGBT populations at the age of 18 because we're not going to address this growing HIV epidemic if we just wait until people are 18 to start addressing it. We know that across development, there's changes in family relationships, legal rights, brain development, risk-taking behaviors. People don't remember things very well. So if you're asking an 18-year-old about their life when they were 16, they're not going to give you the best data that you need to develop good interventions. And so one of the things that I've really been arguing about in my research and in my writing over the last few years is really the importance of institutional review boards, or IRBs, to work with investigators to apply the regulations that allow this research to happen without parental permission. And so if you've taken a research class, if you've worked in a lab, you probably know if you're involving humans in research, it has to go through what's called an IRB. And they have to make sure that your research follows the regulations for the protection of human research participants. One of those generally applied regulations is that if a person under the age of 18 is in the study, you have to get their parents' permission. The regulations allow the IRB to waive that, to say, this study, that's not an appropriate protection for these participants. It also allows the IRB to say that this is actually not a child, because the federal regulations defer to state law in terms of defining what a child is. So if an individual can consent to an activity without their parents' involvement, it would not be appropriate to require their parents to give that person permission to be in a study. And so what you might not know is in most states, Missouri included, anyone around the age of 12 or 13 can consent to getting an HIV test without their parents involved. So some have argued, for example, the Society for Research on Child Development, the Institute of Medicine, the National Academy of Science, the Office for Human Research Protections, the FDA, have all argued that in many of these cases, research on HIV amongst individuals 13 or over, or when they meet the state criteria for self-consent, they're not children under the regulation, so it actually wouldn't even be appropriate to get parents' permission. You'd be adding an additional burden to those individuals. You'd be reducing their rights by requiring another person to consent to their engagement in that activity. And you can imagine why these state laws cropped up. Why do we let 12-year-olds get an HIV test? Why do we let 13-year-olds get tested for STDs? And it's because state governments have recognized the consequences of not doing that. They've realized that we don't want a 13-year-old girl who has chlamydia because she's been sexually active to not get tested and treated for it and then develop pelvic inflammatory disease, become infertile for the rest of her life because she didn't want to tell her parents that she was sexually active, and therefore if that requirement existed, she may never get tested and treated. Same thing for HIV. We want people to get tested. We want to get treated. We know teens don't like to talk to their parents about sex, and that's why we have these laws that allow them to self-consent to these activities. And I would argue if they can consent to an HIV test or an STI test, they can consent to the research on those topics. And I'm joined by many others in making that argument. Recently, I've actually started writing grants and getting funded to do projects focused on these ethical issues. I find them very fascinating about how we think about adolescent involvement in research. And one of the frameworks that I've been really taken by is what's called Goodnessoffit ethics, which is really the sense that when we think about the ethics of a situation, it's the fit between the vulnerabilities of the population and the protections that you put in place that define the ethics. Nobody is inherently vulnerable. They're vulnerable in a particular context. And if we can change that context, that vulnerability may go away. So it argues that really adolescence is not, by definition, a vulnerable population if we put in place protections that reduce that vulnerability. And research is one way that we can understand that. And evidence-based research can inform our decision and the decision-making by IRBs. So I recently received a grant from the National Institute of Minority Health and Health Disparities to actually get perspectives of teens about what it's like to be in research, to help understand what protections teens would want if they were in a research study. And we've also more recently started talking to parents and learning parents' perspectives about their teens being in research as well, which has, I think, been quite interesting. And I'm going to jump through some of the findings, but essentially it replicates what we found in the sense that most teens won't be in sexual health research if they have to get their parents' permission. And here's a quote actually from a participant. If I had to ask my parents for permission to be in that study, I would not do it. Coming out to them by asking to be in the study would be a big shock for them. Plus, in order to be eligible for this study, you have to be sexually active and not always use protection. And if my parents found out either of those, I would probably be grounded for the rest of my life. So if you're choosing between being grounded for the rest of your life and being in a study, what are you going to choose? If we don't do the studies, we don't have the evidence, we don't have the programs, the epidemic grows. Here's another example from a participant. If you can buy condoms without parental permission, which adolescents can do everywhere in the United States, and have sex without going, hey mama, I'm going to go have sex, be back in 2 hours, then you should be able to get testing without your parents' permission. Interestingly, we've shown in a series of studies that teens can understand informed consent forms. There's literature showing that around age 14, the understanding of a consent form is pretty much indistinguishable from an adult. And there's also ways that you can make consent forms more understandable, which we should all be striving to do, that even further reduce those differences. We've also started talking to parents recently, and what we found is that the more you explain the research to parents, the more they understand why you would waive parental permission, and the more they accept that that's a reasonable research approach. So I'm going to shift gears now and talk a little bit, okay, so we understand there's an epidemic, we understand that this research is possible. The question is, how do we do it? How do we reach young people with HIV prevention? And one of my interests in this has been the idea of how do we reach young people who may not even be out to someone yet. They may have not even told someone their sexual orientation. How do we reach them with interventions and services? And I was really taken by a study that came out. It was actually done by a community organization in the 90s called Out Proud, where they actually surveyed almost 7,000 LGBT young people. And at that time found that the majority of teens said they came out online before doing so in the, quote, real world. Now, you can tell this was in the 90s because nobody talks about online versus real world anymore, but that used to be a thing. We weren't all online at all times like we are now. But that study impacted me because it made me really think that if we use the internet, if we use new media and technology as a way to reach people, we might be able to reach them in ways we couldn't do through traditional approaches like school-based interventions and community-based interventions. It would be a way to reach them directly, even when we know that there are laws in place that say if sex education happens at school, it has to be anti-gay, but we could deliver an intervention directly online to those populations without those same laws applying. And so I'm going to talk about an intervention that I've developed called Keep It Up. We call it Keep It Up because it's actually designed for young men that just tested negative. So they go in for an HIV test, they get a negative result. The goal is for them to keep it up and stay negative, which is why we call it Keep It Up. We focused on young gay and bisexual men for the reasons I described before. They're disproportionately impacted by the epidemic, and there are not good interventions out there for them. We also thought that it would be really interesting to link an online program to a face-to-face encounter. So people get an HIV test in person, they go to a community organization or a health clinic and get an HIV test. What can happen then is at the end of that test result, the counselor can say, I think you should do this online program. And the reason we thought that was important is because prior HIV research really did not do a great job of enrolling people of color. And we know that people of color are disproportionately impacted by the HIV epidemic in the United States. And we thought that perhaps that face-to-face experience with a counselor might be a way for us to engage communities of color more effectively by building on this large public health service of HIV testing. Now, Keep It Up has been a long road for me. I started my first version of Keep It Up in 2007 with what's called an R34 grant from NIH to develop and demonstrate the feasibility and acceptability of the intervention. We then actually got funded by the city of Chicago to implement Keep It Up as a service to young gay men in the city of Chicago. We continue to study it, evaluate it, understand it. In 2012, I got an R01 grant from NIH to test it as a 3-city randomized trial where we randomized guys to keep it up versus sort of basic HIV education. I'll talk a little bit more about the differences in a second. And now Keep It Up has been started to be delivered as a service in Jackson, Mississippi. And just last month, or a little over a month ago, we found out we got a large grant from NIH to actually do an implementation trial where we're going to be rolling out Keep It Up in the 75 largest US counties in the United States to really understand how do we scale this out and get it to populations. This gives you a little idea of what Keep It Up looks like. What does an e-health program look like? And one of the things that's unique about Keep It Up is as we were developing it and looking at other HIV prevention programs, most HIV prevention programs that were out there kind of followed this typical format of the first session was HIV is a virus and here's how it's transmitted. These are the transmission routes. Here's why you should use a condom. Use a condom, use a condom, use a condom. And not really putting that information in the context of people's lives. And we know that making those decisions is not so easy when you're in a romantic relationship, maybe when you've been drinking at a bar. And so we contextualized all of the education material within different settings and experience. So there's the first module, which I'll show you a piece of, is really about people's relationships, their connections to their community, their family, really understanding that your health is more than just a single behavior that you might engage in. Then we talked about meeting partners online. Now we talk about meeting partners on apps instead of online because it's 2018. We have a soap opera where we follow a cast of characters. And one of the things that happens in that soap opera is you realize the assumptions that people make. The assumptions that people make in a relationship about monogamy. If you don't talk about monogamy and you assume that you're monogamous in your relationship, it may turn out that your partner isn't making that same assumption. The assumptions people make about someone's HIV status, the idea that everyone might assume that somebody else is going to disclose HIV within the relationship. And if an individual is positive, they may assume it's the person who's negative's job to bring it up. The person who's negative may assume it's the person who's positive's job to bring it up. The point is you shouldn't make those assumptions. Everyone's responsible for starting those conversations. And we talk about dating and healthy relationships. We do goal setting, and then we follow up on those goals with booster sessions 3 months later and 6 months later. This will show you a little snippet of one of the videos that's actually right at the start of the Keep It Up intervention. One of the things that I found really important was using storytelling and hearing people talking about their experiences in their own words. So what we did is we just set up a camera on the street and started interviewing people as they were walking by about their connections to their family, their community, their decision making about safer sex. And what you'll see is that they say it much better than I could ever script.
So I like to be able to do whatever I want to do anytime I want to without having somebody call and check on me all the time.
That's a stop. What do I like about wearing condoms? I like the peace of mind that it gives me. I like knowing that I'm being responsible.
Keeping you protected, safe, drug, disease-free.
That's the one.
I like wearing condoms because, again, there's like the safety aspect. Sometimes you can get like the colored ones, and then it's just like, it's fancy. And like, then you don't get gonorrhea.
Tricky.
So this is one of my favorite things. Ever since we did this project, I've just loved doing video interviews with people because people just say the most amazing things when you start talking to them. We did another video project called I Heart My Sexuality that you can find some of the videos on our website where you just ask people, what do you like about your sexual orientation? And it was amazing to hear what people said. Most people would say, no one's ever asked me that, and then go on to say the most amazing things. So I just love these videos, and you can see how it really is powerful to hear from people like you, like the participants, versus a doctor in a lab coat telling them they should use a condom. So just a little bit about how we've evaluated Keep It Up. So as I mentioned, we just finished a randomized control trial. We compared Keep It Up, which has this sort of content that's engaging, storytelling, soap operas. There's a virtual reality bar that you can go into and interact with different characters. And we compared that to sort of typical HIV education, which we defined as more or less a series of PowerPoint slides that was like, HIV is a virus, and here's how it's transmitted. You should use the condom. Here's what syphilis is, et cetera. So we compared those as two different randomized arms. We had 900 young gay and bisexual men ages 18 and 20 to 29 that were in the study. The outcomes that we assessed were self-reported condomless sex, as well as sexually transmitted infections. And one of the things that we did that was unique in the study is we actually mailed people kits to their home where they could, some participants actually self-tested for HIV. There's an FDA-approved self-testing kit for HIV. We also had them self-collect samples that we did STI testing on. And that was one of the things participants loved about the study the most, is the free STD tests that they could do through the mail. It was super convenient, and they really liked it. We followed up with them at 3, 6, and 12 months over time. We had excellent retention. What you see is at baseline, 13% of the participants tested positive for a rectal STI. If you didn't know, you can get STIs in multiple places in your body, and you should test all of the places in your body that you have sexual contact. Talk to your doctor about that if it's relevant. So here's the effects of the intervention. As I said, we collected these things at baseline 3, 6, and 12 months. What we saw is actually both groups did show a decrease in condomless sex behaviors. Over time, there was a significant difference at 12 months that the guys who were randomly assigned to the Keep It Up intervention had a bigger difference. They had lower engagement in risk-taking behaviors at 12 months. The biggest effect, though, we saw was for STIs. This is the first e-health study that's actually ever been done around HIV that had a biomedical outcome of STIs. And what we found was the guys who were randomly assigned to the Keep It Up intervention had a 40% lower rate of STIs at the 1-year follow-up. Huge effect. We were really blown away by that. We thought maybe we'd see a 10, 15% reduction in STIs. A 40% reduction was a huge effect, and those results just came out in American Journal of Preventive Medicine very recently. The other good news that has happened since that those results came out is that this number has moved from 2 to now 3. So I just got a letter from the CDC a couple weeks ago that they're including Keep It Up as a best evidence intervention. So now we have 3 interventions for this population. The other thing that I'm doing now is really trying to understand the question of how do we get these programs out to the population. So we know it works. We've done now several studies showing that Keep It Up works, reduces HIV risk behaviors, but how do we get it out there? It's not something a doctor is necessarily going to prescribe to people. Who's going to pay for it? How do we deliver it? Who's going to support it? And I think that as somebody who's done e-health research now for over a decade, one of the things that we used to always say in our grant applications is, give us the money to build this and test it, and then everyone's going to use it. Well, the reality is that's just not how it works. Even if this worked amazingly well, which I think it does, it's not like we just flip a switch and it's out there and all these young men are going to start Googling Keep It Up and find it and go through the intervention on their own without any help. We have to understand how to get it out there, how to get it to people who need it. And so that's really been a big focus more recently of my research, is what we call implementation science, which is really the scientific study of strategies for the implementation of effective interventions. And what we're interested in now is sort of what's the model for the delivery of a program like this. Traditionally, HIV prevention is done where you get on this list of evidence-based programs. The CDC gives out money either directly to health centers or to departments of public health. Those departments of public health give it to the health center to implement that prevention program in that organization. Well, we started talking to these organizations and we said, could you run an e-health program out of your community health center? And they said, we don't know anything about that. We don't do e-health. We don't have a web, we have a website, but we don't deliver interventions in that way. And so we realized we had to really figure out how do we create an intervention, maintain it, support it, and then make it accessible to these organizations. And so we've really been kind of studying that, and very recently we got a large, nearly $9 million grant from NIH to study this question of how do we disseminate and implement these e-health programs. So we're doing what we're now calling Keep It Up 3.0, which is an implementation trial, which means we're actually randomizing counties to do one of these two strategies. We either fund a community-based organization to implement Keep It Up, or we actually implement it from Chicago. We do recruitment through advertising, we ship people kits, they do everything through the mail, they do everything online themselves. And really what we're comparing is which strategy works better. So we're taking the 75 counties with the largest number of young gay and bisexual men, we're randomizing them 2-to-1 to get one of those strategies. And then we're going to follow and look at these implementation outcomes of who reaches people better, who retains people better, who reaches high-risk people better. And so and then what's the cost of delivery? You could imagine us doing it all from Chicago might be the most inexpensive, but maybe we don't reach the people the best, maybe we don't retain the people, maybe the engagement isn't as good. So we really want to compare those and see which strategy is most successful. So I started out talking about teens, and then I showed you a bunch of research on young adults. And I'm aware of that. And so now I'm just going to switch gears and say that I am also paying attention to teens and HIV prevention in teens. And also kind of consistent with that idea of implementation research, I have another project called the SMART trial, which is actually testing a stepped care strategy. And so when you think about, if you go to your doctor and they say you have high cholesterol, and they say, we're going to give you this statin to take, and they give you a low dose of it, and you take it, you come back 6 months later, and your cholesterol hasn't gone down enough. The doctor, what does he do? She says, we're going to increase your dose of this medication, so that will bring your cholesterol down. They don't say, we're just going to keep giving you the dose, because that's what we prescribe to you. We do that, unfortunately, in behavioral interventions. We often just keep giving the same dose of the intervention. We say, this is the package, this is the intervention, we're just going to give it to you. Whether you respond to it or not, this is what we have, just keep doing it. And so what we're trying to move is into this idea of more of a stepped care strategy where we give somebody something, we see if it works. If it doesn't work, we increase it, we give a more intense intervention, and we keep increasing the intensity of the intervention until we find something that works for that participant. And we're evaluating in what's called a SMART trial, which is a sequential multi-phase adaptive randomized trial, or SMART. We also call the project SMART because we thought it looked cute as well for young people. And the components that go into SMART is we start by delivering universal sex education to all of the participants in a project that we call a queer sex ed. It's sort of sex education that we think everyone deserves to get. If they don't respond to that, excuse me, they get stepped up to an adolescent version of Keep It Up, which is much more focused on context, motivation, skills, much more intensive. We call that the SMART squad. If they don't respond to that, they get stepped up again to individualized motivational interviewing sessions via video chat with a counselor. So it's sort of increasing the intensity. And of course, at the same time, the cost is more expensive. Having a counselor talk to a teen is much more expensive than having a teen review a sex education website. So we're measuring cost, and we're trying to understand how do we give the right interventions to the right people. And if they get more expensive, we want to make sure they're getting to the people who need them the most. And so that's a project that we're just in the middle of enrolling participants for now. We'll eventually enroll almost 2,000 13 to 18-year-old gay and bisexual boys in the trial. You can see this is a graphic that shows the randomization sequence. Quite complicated for these SMART trials. You need very large samples in order to evaluate these sort of stepped care strategies. But they're really valuable at the end of the trial. You have a lot of information about what works for who needs what, how to move people through a sequence like this. And so we're really excited about that. And it's one of our first projects that will be fully bilingual. All of the intervention will be delivered in English and Spanish. And so we think that's also an important development. So that kind of concludes what I wanted to talk about in terms of some of the issues of health equity, what I see as driving them, some of the interventions that were developed, and a little bit about how I've sort of moved through this trajectory in my career of doing observational research, doing interventions, showing they work, and then beginning to study the implementation. And I just want to conclude by, I mentioned that we did this project called I Heart My Sexuality. We had young people do videos. One of the things we also had is them write on cards at a Pride event what they like about their sexual orientation. And I think it's just important, as I talk about health disparities, it can sometimes begin to feel like all LGBT youth are doing poorly and have mental health problems and are at risk for HIV. And the reality is most LGBT youth are thriving and doing well, and it's really important for us to remember that. And I think these cards, in their own words, gives us an important way of doing that. So thanks to the youth that are participating in the research. Thanks to the many different federal agencies that have funded my work over the years, and foundations, and also to my staff that make all of this work possible. So thank you, and I think I've got some time for questions.
Federal or cultural support for your work in the last 2 years?
No.
No? That's great.
Doesn't mean I won't in the future, but I have not as of yet. And I will say I'm on the advisory committee to the Sexual and Gender Minority Research Office at NIH, and we've actually seen a small increase in NIH funding for SGM issues over the last year. So science is so far still proceeding at the NIH.
Okay, Brian, so I know that the earlier part of your talk, you're talking about like some of the cultural contextual factors that sort of lead this beating down of LGBTQ teens and youth. Sort of a small potatoes question that's related. I'm curious, have you thought much / do you know much about the concept of sort of, I don't want to say queer on queer hate, let me phrase, biphobia that exists amongst some in the gay community against this other subset of the...
Yeah, absolutely. No, I think I'm glad you raised that point. So some of the discussions I've been having with people today is a little bit about where I see work heading in this space of LGBTQ health. As the director of this large institute, I worry not only what we're doing, but also what's happening in the field, because we really want to move work forward that's not getting the recognition it needs. And I think bisexual health is a huge piece of that. It's one of our areas of strategic growth for our institute. Bisexually identified youth are the largest group of SGM teens. There's more bi-identified youth than gay-identified youth. But we've done very little research to understand the experiences of bisexual youth. We know that when we look at a variety of different outcomes like suicide attempts, substance use, the bi youth have more problems, more challenges than the gay and lesbian youth. And yet we know very little about their lives, their experiences, and I think part of that has been a stereotype that unfortunately has existed in academia as well, that for youth, bisexuality is just a phase. They're probably going to later identify as gay. We don't need to pay attention to them as a population. And I think we're now understanding that that's just a ridiculous idea. And so we are beginning to do more and more research on the experience of bi youth. I'm happy that our institute's recruited 2 new faculty. Their primary focus is on bisexual health. And so I think in the coming years, we'll understand more about it. We did start collecting some data on biphobia and experiences of bisexual discrimination in our cohort study of young gay and bisexual men. Our Brian Feinstein is the faculty who's leading that work. And I just saw an early draft of the paper, but we are looking at experiences of biphobia from heterosexuals as well as from lesbian, gay, bisexual people. So give me a year and you'll probably see a paper come out on that topic.
Thank you
Yeah, that's a great question. So the question is, we saw a much bigger biological effect than we saw a self-reported behavioral effect, and why is that? It's something we've been really pondering, and our hypothesis is that because Keep It Up was so much about context and experience and knowing your partners and the importance of thinking about testing before you might discontinue condom use, we think that there's probably contextual factors about who they were having sex with that might explain those differences. Unfortunately, we didn't measure those very well in the trial. So these are, unfortunately, at this point, it's just a hypothesis. But we think that perhaps those occasions where condomless sex was occurring was at a lower risk for disease transmission because it was with a partner, maybe they both got tested together before they discontinued condom use. That's what we think, certainly something we need to study more, and I appreciate that question. Yeah, thank you.
So have you considered, or are you currently planning to kind of integrate the two areas that you talked about today with the impact of relationships on kind of healthy development and this sexual context of STI transmission? And are you planning to integrate those two areas?
Yeah, also a great question. Thank you. So one of the things that we've actually observed, and I didn't present the data, but myself and other researchers have shown that actually the majority of HIV transmissions that occur in young gay and bisexual men occur in the context of a serious relationship or a primary partnership. And that's actually, I think, very important for people to know. There's a lot of assumptions that HIV transmission occurs in a hookup, casual sex encounter, but the reality is most transmissions are occurring in a more serious type of relationship. And it makes sense when you look more in depth because what we see is that young people use condoms when they're in casual sex encounters. They stop using condoms as soon as they think the relationship is serious. And so that's, of course, where any kind of disease transmission would occur. So it's something that we're very focused on. We do address a lot of aspects of healthy romantic relationships in both Queer Sex Ed and Keep It Up. But I think even better than that is some work that's being done by my colleague Michael Newcomb, who's in our institute, who's now testing an intervention called Together, the number 2 Gether, which is a relationship education and HIV prevention program for young men in same-sex relationships. So they actually bring in groups of young men who are in same-sex relationships. They talk about healthy communication, keeping your relationship happy, problem solving within your relationship. And then they also talk about HIV and how to prevent it and how to get testing and prevention behaviors and making a goal for the couple in terms of preventing HIV transmission as a goal for the couple. It's an amazing program. He's right in the middle of doing a randomized trial of it. I was talking with somebody earlier about the control arm for that is actually mindfulness and a positive affect mindfulness intervention for the couple, which we think actually might help them, but probably not in terms of HIV prevention. So we're kind of hoping both arms do well, but on different outcomes. And it's actually been a very popular program. He's delivering it both in Chicago, and then he got another grant to do it online and deliver it actually online, which is a nice way to meet couples who may not want to come in, face-to-face, or the scheduling issues that happen with kind of face-to-face small group intervention. So I think it'll be probably 2 to 3 years from now. Hopefully those results will be out, but I think it's an exciting and important development.
And what's the target population for that?
That's one of the participants has to be 18 to 29. Their romantic partner can be any age. So if you're interested in enrolling, go to Together at Northwestern, and you can find the screener.
Looking at the data set, you showed that the effects of Keep It Up at 3, 6, 12 months. Do you have any plans for more longer longitudinal study?
Yeah, no, it's interesting. I don't currently. I think right now for the Keep It Up 3.0, where we're doing the implementation trial, we're probably still only following people for a year, which is hard for me because actually my first study, Project Q2, was a longitudinal study. It was supposed to be a 1-year study in 2007 of LGBT youth, and now 11 years later, they're still in the study. We're still following them, over a decade of their life. So I do have a reputation that when people join my studies, they never leave, that they stay in my studies for the rest of their life, which is I kind of like because it's amazing to me when I see somebody come back for an interview like a decade later, people who've actually grown up being in my studies. But so far for Keep It Up, we don't have those plans, but it's a great question.
You talked a lot about physical health, but what about mental health among this population? Are there interventions that are available in place?
Yeah, I also see that as a surprising area of deficit. Most of what's been done so far in that area has been about documenting the disparities and maybe beginning to understand the mechanisms, but we really are quite anemic, I think, when it comes to interventions. I do have a colleague, John Pachenkis at Yale, who has an intervention called, I think it's called ESTEAM, which is about teaching coping skills, about teaching skills kind of based on that, like CBT, cognitive behavior therapy principles, and using that as a way to prevent mental health problems in young gay and bisexual men. And I think he has a trial going on right now of it, but it's definitely an area where we need a lot more attention. We also see big substance use disparities, and we also don't, most of what we've been doing so far is documenting their existence, and I think we really need to move into the intervention space for that as well.
Any more questions? Yeah.
So thank you so much for your talk, and I really appreciate the intervention on the level of promoting resiliency on the individual level, but I'm wondering if you have any career plans or goals for this research on more of a socio-political or public policy level.
Yeah, that's a great question. So I talked in the beginning of my talk about these multiple levels, and then I talked about interventions that are all at the individual level. So yeah, that's a good observation. I would say a couple of things. One of the things, and I was talking to somebody earlier about over my career, I kind of get obsessed with specific things and I move into this technique and then eventually get obsessed with something else. But there was a period where I was quite obsessed with network science and understanding networks of relationships that people have. I'd still say I'm moderately obsessed with it, but it's subsided a little bit. Anyway, one of the reasons I got interested in it is when we look at these big racial disparities in HIV, we see that young Black, gay, and bisexual men, if nothing changes, about half of them will be HIV positive by the time they turn 40. I mean, this is just, something has to change. But so there's this big racial disparity. You might assume that it's individual behaviors that are driving this disparity. But study after study has shown young Black gay men are more likely to use condoms, have fewer partners than their white peers. And they use less drugs than their white peers. So from every individual level behavioral indicator, that disparity shouldn't exist. It should be in the opposite direction. And so clearly there's something beyond individual behavior that explains that. And so one of the things we started doing is collecting network data about what are networks of sexual relationships, friendship connections, resources, supports. And one of the things we found is big differences in the sexual networks of the Black young men versus the white young men that really go a long way in explaining these disparities. That, for example, young Black men, there's fewer venues at which they go to, partially because many venues are not seen as welcoming to young Black gay men, so gay bars, for example. And so if there's fewer venues, then everyone connects through a few sets of spaces, which is exactly how disease transmission would happen. And so that really does point to the need to think about these things structural, that we can't just focus on individuals. And I want to move more into that area in the future. I have to admit, I was invited by the psychology department, so I probably shouldn't say this, but my deficit is that I am a psychologist and I tend to focus at things at the individual level and what people think and do and behave. But I see that a lot of these things are not going to be solved if we just focus on the individual. So I do hope to move more into those areas in the future. So thanks for your question. I might have time for one more. There is one. Okay, well, thank you.